Today I'm going to be talking about a series of pieces of research we've conducted in the UK looking at the LGBT community's experiences and access to palliative care. So looking at those experiences of people who identify as lesbian, gay, bisexual and trans. So why in particular are we talking about the LGBT communities? We first conducted a systematic review 10 years ago now, which looked at the needs and experiences of LGBT people towards the end of life. And what we found was that there were higher rates of certain life-limiting illnesses amongst the LGBT communities, higher rates of certain cancers. There were also higher rates of risk behaviours, drinking, drug use, smoking, often linked to discrimination. There were also fears around accessing care, which meant that people would tend to present later, be more sick when they came to access the care that they needed. They had a lot of fears around discrimination from healthcare providers, and particularly in the context of end-of-life care, where in the UK, many people would have been excluded from care settings when during the HIV pandemic. There are still concerns that people have around accessing care in hospice settings, particularly when they are linked to churches and other faith-based institutions. And there are recognised inequalities in access to hospice care generally in the UK. So we knew that this was the general picture of the experiences for LGBT communities, but we didn't really understand what the particular challenges were and what could be done to improve it. So we set out to do a study to look at the experiences of LGBT people accessing palliative and bereavement care in the UK. This was a study funded by a charity in the UK, Marie Curie, and you can get a sense of where we managed to get in this study from the map on the screen. Importantly, this was a study that we conducted with community representatives. The study was an in-depth interview study, and it required clinicians to refer people to us who had shared that they identified as a member of the LGBT community and were living with a life-limiting illness or facing bereavement. But obviously that only manages to reach those people who have felt comfortable to share that information with their clinician. So we also had an arm of the study where people could self-refer if they had experiences that they wanted to share. And we got roughly half of our participants from self-referral to the study. So as a brief overview of what we found from this study of 20 in-depth interviews across the UK was that many people had positive experiences to share in healthcare settings, feeling recognised and understood as who they were. But there were still many experiences that were not so positive. Concerns around sharing who they were, who was important to them, and their identities. And this sense of making a risk assessment every time you're in an encounter with a clinician, whether to share that information. There was a lot of presumptions that people were in a heterosexual relationship. So presumption that the man that's with you is your husband, for example. And this led to barriers in communication and building trust. There was also a lack of sensitivity around needs and disclosure of identities for trans people in particular. And there were fears really related to previous experiences of discrimination. And these then shaped people's preferences for whether they talked about their relationships. So what this looked like in the clinical setting was that an individual would be seen who had those holistic care needs, those physical, psychological, social, spiritual needs, but they also came with barriers themselves, which were in the shape of stressors and fears and previous experiences of negativity that they'd experienced both socially and in clinical settings. And therefore, their encounter with the clinician in front of them could be positively or negatively affected by what that person said to them, how they responded when they shared information about their LGBT identities, but also service level barriers and stresses too. And I'll talk a little bit more in detail of what these things look like. So there were differences in clinical needs that people talked about. We asked everybody whether they felt their needs were different in some way because of their LGBT identity. And one of our trans participants talked specifically about the conflict for her between her hormone medication and her health. She had taken estrogen for many years and developed blood clots in her lungs and had been advised that she should stop taking estrogen. And she said, if somebody said your heart will stop in 10 minutes, of course I'd stop. I had to work out what was the risk, what was acceptable. And it's easy for somebody else to say it's acceptable, but we carried on. So this sense of having to weigh up your sexual orientation or your gender identity against your health was quite unique to these individuals. There were also experiences talked about with individual clinicians themselves. Fiona talked about hiding who she was, always fearing that at the back of her mind somebody would be negative about you. She said it's not so much about the individual, but about a risk assessment around it. So she said, you spend a lot of energy trying to work out at what point in the conversation do you actually acknowledge or do you state your sexuality. It's not usually about the individual, it's about a risk assessment around that. And there were also assumptions made about participants. Harry was a young 27-year-old man living with motor neurone disease, presented with his husband. They had 2 adopted young children. And the consultant they still said, well, I'll talk to you more about this when your brother's back in the room. So making an assumption about that relationship. So there were many different experiences that people talked about, but they talked about the importance of things at an individual level from the clinicians themselves and from a service level. So we developed 10 simple recommendations to improve care for LGBT people. And these avoided quite simple things, really, but they all came from the evidence. So avoiding heterosexually framed or assumption-laden language. So avoiding putting a label on a relationship unless that's been disclosed to you. Trying to be sensitive to the needs of individuals around disclosing their identity. For some people, that's not going to be something they're happy about. And carefully exploring the relationships to understand who's important to that individual, including biological and chosen family. And importantly, explicitly including partners in conversation and recognizing the importance of them. One of our participants, her partner wasn't able to attend an appointment with her, and the clinician said to her, oh, where's Sue today? She's always with you. And that sort of level of just engagement with that relationship was really important. But our participants also talked about the
degree to which that individual feels able to share the nature and depth of their relationship to those around them, and how that is responded to by those around them. So individuals will experience things differently based on those 2 factors. For example, somebody who is able to talk about their relationship and their loss to those around them, and for whom that loss is acknowledged, would be in a position of societal acceptance. In contrast, somebody who doesn't feel able to talk about their relationship and therefore nobody knows they're facing bereavement would be in this position of invisibility. So having developed this model, we thought it would be interesting to look to see, well, what can we understand about outcomes in bereavement for the LGBT community? There's very little evidence out there, so what can we find out? And we designed a study called Access Care B, Bereavement, the second of our studies, which was designed to be a comparative retrospective post-bereavement study to compare outcomes in bereavement for people bereaved of a same gender partner and people bereaved of a different gender partner. And this study was conducted drawing on support from the Office for National Statistics in the UK, who deal with the registration of births and deaths. So using the gender of the person who had died and the gender of the person who was registering the death and their relationship label, we were able to identify people who'd been bereaved of the same gender and other gender partner. And I'm just going to talk very briefly in terms of highlights of this piece of research. The first point I wanted to mention was around psychiatric caseness. So we used the General Health Questionnaire as part of our survey that we sent to individuals, as well as the inventory of complicated grief. And we were able to compare those across these two groups. And the first important finding we had was related to psychiatric caseness. So whether somebody would be considered to have a psychological concern. And we found that those who'd been bereaved of a same-gender partner were more likely to meet the criteria for psychiatric caseness than those who were bereaved of an other gender partner. And similarly, this also held up for psychiatric symptoms. So individuals who were bereaved of a same-gender partner had much higher levels of psychiatric symptoms than those who'd been bereaved of a same-gender partner. So we were able to see quite how that model might play out in terms of individuals' outcomes in bereavement. And we're in the process now of finalising some of the qualitative work, which goes on to explain that in a little more detail. The third study I wanted to just briefly touch on was some of our work we've conducted in Zimbabwe. This is important because although in the UK the situation is legally much improved in terms of the LGBT community, there is recognition of the LGBT community and legal recognition of same-gender relationships. There are many countries where that's not the case, and there may be people who you're delivering care to who have recently come from somewhere where the situation is very different. So we conducted a study in Zimbabwe trying to understand experiences there in relation to access to healthcare and palliative care. And I'm just going to talk very briefly through some of the highlights from this study. There were three main themes that emerged from this study. The first related to attitudes towards illness. For people who were LGBT and sex workers who were also interviewed as part of this study, illnesses were thought to be caused by bad behaviours, brought upon themselves, and they deserve blame, not compassion. The second theme was that access to healthcare and palliative care was conditional on conforming to sexual norms. You must pretend or deny in order to access healthcare. And that healthcare and support by health workers was determined by personal attitudes rather than professional ethics. And I'll just show you what that looked like in some of the data. So bad behaviour, deserving what they get. One of our palliative care nurses talked about, there's a prostitute that lives down there who's now having HIV and AIDS. She used to take other people's husbands. Most people will say, let her suffer. It's her time now. She used to make others suffer, so it's her time. And one of our participants said, they say we're doing something illegal, which is prostitution, so you won't get the medication. They won't get it when they have it. There was also a sense of personal attitudes overriding professionalism. The quote at the top here from a palliative care nurse, this is a taboo and abomination. What are you doing? No wonder you're in this situation. So again, very much this strong sense of blame coming through. And a lot of that was related to faith and religion. The second participant said, quite honestly, in the first place, I think to be a lesbian or gay, it's a sin. It emanates from how I understand the Bible. My view comes biblically that it's a sin. And these personal attitudes and faith overrode individuals' professionalism. And the third area I wanted to mention was around lying and hiding and pretending to be someone else in order to access services. One of our participants talked about taking somebody that she'd met randomly on the streets to access sexual health services because presenting with a man, then she would be given the care that she needed, which she wouldn't if she took her girlfriend to the clinic. But people also talked about how difficult it is in Zimbabwe to talk about sexual orientation and identity due to risks associated with that. So a very stark difference in terms of the experiences that people describe, but a really important context to be thinking about when delivering care. And the final aspect of our research I wanted to talk about focuses specifically on communication. And I think this is the thread that runs really through all of these studies, is that the experiences for individuals are so fundamentally affected by how conversations and interactions happen in relation to their healthcare. And they can have real consequences in terms of whether or not somebody accesses the care and support they need it when they need it. So this was a large study, again, conducted across the UK, which utilised in-depth interviews with LGBT people affected by serious illness, their significant others, so often partners, but also other relatives and friends, and healthcare professionals. Now, we chose specifically to do this in the context of serious illness, as we thought if we can get it right in serious illness, we should be able to get it right across the board in healthcare. We also made a very purposeful decision to include health and social care professionals. We have some evidence around individuals' experiences accessing healthcare, but we wanted to know, as a clinician, what are the things that worry you around having conversations about sexual orientation and gender identity, and what experiences have you had which have shaped your practice both positively and negatively? Have there been experiences that have meant you shy away from having these conversations now? So what we wanted to understand were what were examples of good practice in relation to communication, and how can we guide clinicians to be inclusive in their communication from the outset? It's not about seeing an individual in front of you and thinking, well, I think they might be gay, therefore I'm going to use this language, but thinking, how can I make my language inclusive from the outset? And this work, if you want to see the full paper, there's a link here on screen to access that. But what we've developed alongside the paper is a set of guidance as well, which is called the ABC to Inclusive Communication for LGBT People. And it's ABC as it relates to 3 different elements: approaching all interactions using inclusive language, being aware of yourself and your surroundings and how that may affect the interaction, and creating opportunities to be inclusive and for sharing identities in line with the preferences of the individual in front of you. So just to share a little bit in terms of what that looked like for our participants. So first of all, this approaching all interactions using inclusive language. So one of our participants talked about the real value of using neutral language in terms of gender neutral language in interactions with individuals. For them, using a pronoun they was really important for who they were. They identified as non-binary, so they used the pronoun they. They said, like, referring to me as a person and using they pronouns, that will make me feel more comfortable. So they talked about the importance of that to set the scene, to make them feel comfortable. But that also extended to the labels that you use for the people that those individuals bring with them to consultations. So for example, if you stated to them that an individual is your partner, then the clinician shouldn't change that to husband. They should reflect that, the language that you're using. So these use of neutral language, but also reflecting the language that LGBT individuals use themselves, was really important. The second aspect around being aware of yourself, your reactions, and the surroundings. So one of our participants talked about looking for expressions beyond words. So looking for body language and expressions when making an assessment about how she felt. And apologies, that first quote has gone slightly wrong there. But she said, when I say lesbian, I look for that micro expression behind the eyes, a twitch, or to see how sensitive they are to it. So for her, she looked really for that response from the individual. And that had a great impact on how she felt in those interactions. But also being aware of the surroundings. So for example, when receiving acute care in a ward that was an open ward, people talked about how sound travels through curtains. and that having conversations in open areas may not be something that individuals felt comfortable with. And lastly, creating opportunities for sharing. And this was really important to our individuals in terms of creating opportunities, not necessarily forcing someone to share something that they didn't feel comfortable with, but giving them the opportunity. For example, saying, what pronouns do you use, to give the person the opportunity to share information if they would like to. But also giving them the option not to answer if they don't feel comfortable. So this sense of putting the opportunities out there, but not forcing people to share more than they're comfortable with. A central part to our research programme of the last decade has been the involvement of patient and public involvement members. And there are 3 of our members on screen here, Ruth, Liz and Paul, who have all been integral in all aspects of these studies in terms of thinking about the topic guides for interviews, the questionnaires we've used, but they're also authors on our papers. They've been central to the analysis that we've done as well. And we also take them with us and they present for us at conferences too. So they've been a huge part of our study, our series of studies, and have improved it and have made such a contribution throughout the years. Another part of our work has been broadening out the findings across Europe. So we are part of an EAPC task force, the European Association for Palliative Care Task Force for LGBT people. We have representation from 13 countries now. So we've taken examples of best practice from across those countries and are in the process of completing these evidence-based recommendations within our international network. And if that's something you'd like to learn more about, then do please get in touch. So that's really what I wanted to talk about today, and my sincere apologies for the technical glitch in the middle. This is a bit of a sense of the outputs we've had from these studies, the papers, as well as the reports. We also developed some guidance for patients and caregivers as well around why it might be important to share who you are and who's important to you. So we've taken an approach of trying to develop guidance both for individuals themselves and professionals to try and create as inclusive a environment as possible for individuals. So thank you very much for your time, your patience with the technology. Thank you.
Thank you, Catherine.